Paul Michael Steen.
Okay, so Dr. Steen. And what is your specialty, Dr. Steen?
I'm an internist.
Okay. And where did you go to medical school?
I went to Downstate Medical Center in Brooklyn.
In Brooklyn.
In 1961, I started.
61, okay.
Right.
And then when did you graduated then in 65?
Correct.
Okay. And when did you first start practicing outside of residency?
1971 here in Worcester.
Okay, 71. Have you been in Worcester the whole time?
Well, I practice in Southbridge, Mass. Actually,
Okay.
that's precisely where it.
Okay.
Right.
Okay.
I
But
was in
the Central Mass area.
Right. I was in a three-man group
When you started out.
when I started out. Right. They recruited me actually.
Okay, great.
Mm-hmm.
All right, so let's start by talking about some of the early days of your practice.
Mm-hmm.
Did you start out in the three-man group that you just described?
Right.
And I think that you and I have talked before. During residency, you had some very interesting experiences before you went
Right.
into practice.
Correct.
Okay, can you tell me a little bit more about that?
Well, we actually were looking at pretty poor paid internships and residency. It was $3,000 a year. That was your total salary, from which they subtracted laundry and taxes.
Laundry for like the scrubs and whatnot.
Right, exactly. So there wasn't a lot of money. And when I was chief resident, I was chief medical resident in my last year at Kings County. We formed the five city hospitals formed what would amount today to be a union. It's called the Committee of Interns and Residents.
Okay.
And I came from the hospital I trained at was Kings County Hospital, which was at that time the second largest hospital in the world. We had 3,700 beds, so it was a monster place. So we had a lot of priority in this conversation. And the chief of surgery, and myself as chief of medicine, we represented Kings County at this. And we met with a lawyer, labor lawyer, who looked on us as the last slave labor in the United States, given our hours, because in those days we worked 36 hours on and 12 hours off.
Wow.
Right.
So for a total of about how many hours a week did you say?
Well, you just kept going.
Okay, so there were no limits.
There was no end, right.
Okay.
Now, interns took the worst of that brunt, because even though as a first-year resident I was on call, except for July and August, once the interns got up to speed, you weren't that involved. You could sleep through the night. As an intern in a place where we got 150 admissions a day, even though we had the staff of internal medicine, we had 450 interns and residents in internal medicine, in all the specialties and everything.
Okay.
So it's a mini army. But chief resident was a major business job. You had all the scheduling and stuff. But anyway, so we had this union. We met for a year. Our contract expired, and we just kept working through it on the old contract. And then we met with the mayor, Mayor Lindsay Wagner, and after September, the teachers went on strike, the garbage men went on strike, and the subway went on strike. And our lawyer said, this is the time to threaten a strike. Don't do it. He said, once you've done it, you have nothing left to, you have no negotiation left. So we did, and to our surprise, the mayor said, if you don't strike, as soon as these other three are over, we will settle yours. So we agreed. We took him at his word. And a month later, they raised our salaries to $18,000.
From 3,000 to 18,000.
And they made it retroactive to July 1. So I got a check at Christmas that was equal to all the money they had paid me in the preceding 4 years. It was a great victory.
Good Christmas.
Yeah, it was a great Christmas. It was a very interesting experience to watch a seasoned negotiator like this, like the labor lawyer, talk to the mayor, how we would threaten and then pull back and threaten and pull back. But he said, you never pull the trigger.
Sure.
Because you're done. That's it. If they weather it, There's nothing to come back with. So he said, you just threaten, the imagination is worse than reality. So anyway, that was a great experience for me. The irony of it was, all through the year I spent on this, my hospital kept threatening to fire me.
And why was that? Because of your work with the union?
Yeah, the hospital's a city hospital.
Wow.
And I was getting arguing with the city. It turned out the superintendent of the hospital was the brother-in-law of the mayor. So there was extra tension.
Sure.
And but after we settled, they gave me a plaque
Well, there you go.
commemorating my great duty to the hospital.
Oh, that's
So
really
that was a fun. That was the one big experience. After that, I went to the Navy for 2 years.
okay.
And then I came up here immediately after that. I worked with somebody from Southbridge in the Navy who kept telling me how wonderful it was and what a great little town. He was right. And I looked around, and that's where I ended up settling.
Wow.
Yep.
Okay. All right. So that's quite an experience
Yep.
to have as a resident. I mean, you're still, very green.
Well, they chose the chief resident because they figured we had the most political clout, chief of medicine, chief of surgery.
Okay.
So they thought that they wouldn't fire us even though they were going to threaten it left and right.
Wow. So that's quite a position to be put into.
It was. Plus, my fellow residents were not happy with the pace. This was 7, 8 months of negotiating. And we had some hotheads who wanted to do things like put patients out on the street and stuff like that.
So I was going to ask you, do you feel like unionization in physicians, do you feel that it affected patient care in any way?
No, I
during
don't.
those negotiations?
In fact, a lot of the negotiation was not just about salary. We had a very dangerous emergency room. I was threatened twice in my emergency. Somebody pulled a gun on me.
Oh, by patients?
By a patient, yeah. I was sitting there in the ER doing my ER duty, and a guy walked up to me, put a gun at me, and said, my girlfriend is next. And I said, yeah, you're right, she's next.
Oh.
And he put the gun away and sat down. And I've had friends had very similar experiences. So we wanted a policeman in the ER, and we got that in the negotiation. Plus, they changed hours. After your internship year, you no longer work 36/12. You went on a 24/24 schedule, which was way better, way better.
Imagine.
So there were a number of things we worked on that were for patient safety and equipment we wanted. We had, this was the birth of the ICU, was when I was in training. There were no ICUs when I started, and in my year as chief resident, we wanted to put an ICU in. And we went to look at some of them in the rest of the city. St. Vincent's, New York was the pioneer in the ICU, and they would never pay for it. So it was in the contract. When we negotiated the contract, they had to supply us with intensive care equipment.
Okay, so let's talk a little bit more about that. That's very interesting.
Okay.
To have a world where there's no ICU.
Right, it's hard to imagine it for you, I know.
So, I mean, first of all, let's start with some of the equipment. What were some of the things that you guys were trying to get for your ICU at that time? Do you remember?
Oh, yeah, absolutely. Well, first, we had non-automated respiratory unit. When you intubated somebody, it was the cylinder, the oxygen cylinder powered the respirator. And so you had to sleep in the next bed because the nurses were not allowed to touch it or trained it. It's brand new stuff. And it was tricky because the pressure would change as the oxygen went down, the pressure would change, and the settings would change. Eventually they came, I think the Bird was the first really semi-computerized one, and that started to change things. Plus we wanted nurses to be trained to handle this. There were no pacemakers yet.
Okay.
There was defibrillator, and we had one for a 3,700 bed hospital. And we had 2 monitors. They were this big with a small oscilloscope like that. And it sat on the bedside. And there were 2 of them. And they had no automated equipment. There was no alarm. You actually had to watch it.
So intensive care unit really meant the physician was intensively involved.
Right. You slept. If you had an MI admitted and they went into a ward bed and you slept next to them.
Wow.
Intern slept next to them.
Yeah.
Well, when we finally got the intensive care unit, we did have a first-year resident and an intern in the room. That was also new, and we trained the nurse. We sent them to St. Vincent's in Manhattan, to get trained, because they were way ahead of everybody else on this material. So that was, it was there actually for the birth of, for the intensive care unit. And in those days, an MI stayed in the hospital 3 weeks, minimum. That was the minimum. They didn't get out of bed for 7 days.
Wow, bed rest.
Bed rest, right. And then, I think it was Dr. White up in Mass General wrote this article about ambulating on day 1 or day 2. And we did it, and the first one had a massive MI in the arms of one of my interns, and that sort of set that back a little bit.
Okay. Fair.
Yeah, so then, but we eventually went to that model, and people were out then in 7 days, and then pacemakers came in. I remember putting my first pacemaker in. Somebody had to show us how to do it. Other things, lupus was considered an incredibly rare disease.
Lupus?
Every case would be reportable.
Really?
And then a fellow named Dubois in, I believe, LSU, wrote an article of 1,000 cases of lupus he had collected, which automatically took it out of the rare class. And so he had a whole new spectrum of testing and clinical manifestations, all of which we had before classified in other diseases, which we now brought, that they were just all this kind of immunos type of diseases with unknown etiologies. And he brought them all together, and some of the testing he had done showed that they were related in some way. That was in the 60s.
So it sounds like it was in large part due to reclassification of disease.
Correct.
Was it also sort of related to new techniques for finding them? And sort of how would you diagnose lupus when you first started practicing?
Well, everybody had the butterfly rash.
Okay, so the butterfly rash.
They didn't have that. They couldn't be classified as lupus.
Okay.
So
the sort of multiple points that we learn in medical school were
not there. Right. They were after his, because he listed them. He put them all together. But what helped him was he had some of the immunologic testing that he had developed showed that there was a thread running through all these different presentations. So it wasn't just a dermatologic disease; it was a systemic disease. And so anyway, that was one of the things I remember from back then. We did have heart-lung machine. I was actually on. The guy who invented it was in Minnesota, and he came to become chief of surgery at where I trained. And so I was on the heart-lung team. That's how I worked my way through college.
So tell me more about a heart-lung machine.
Yeah.
I've never even heard that.
Bypass.
Okay, yeah,
Yep.
all right.
But back then it was called the heart-lung machine. It was about this big.
Okay.
And we would crouch under the table, and they would cover us with the curtain, with the sheet. We were literally under the table. The surgeon would be standing next to me, and we were running the machine. And
Wow.
it was about this big cylindrical thing. And that's actually, I got into medical school because I have a degree in engineering.
Okay.
And what they were interested in then, because the heart-lung had come, the dialysis machine had just started to come around, pacemakers, defibs, all that stuff, they thought they needed engineers in medicine. And that's how I got on the heart-lung machine and worked on it. I worked on the dialysis when it moved to, when we got somebody who knew how to do them at our hospital. So anyway, it was a lot of development going on. A lot of stuff that we take for granted today was brand new and changing. I worked on alcoholism when I was I did 3 training periods, electives on psychiatry, all of which I spent in alcoholism. And we did a lot of research on what worked and didn't work. We wrote quite a few papers. I wrote some papers on preventing myocardial infarctions when I was in medical school.
So let's go back to alcoholism.
Okay.
What were some of the thoughts about treatment of alcoholism? Have those changed over time, or do you feel like it's been sort of the same?
Well, it's interesting. When I practiced here, I ran the alcoholism ward here at my hospital. Nobody wanted to treat them. So every
So this
time.
is sort of a detox type situation?
Detox unit. And but we got a lot of DTs, delirium tremens patients, and nobody wanted to deal with those. And so having spent, 3 years off and on working on it, I was very comfortable with it. So everybody said, oh, well, good. Right. Well, we tried a variety of different drugs. The only drug they used in alcoholism back then was something called formaldehyde. I don't know if you're familiar with it.
I've never heard of it.
Formaldehyde is a liquid, foul-smelling, unbelievable. It's a sedative, and they would measure it out and you would drink it if you had to hold your nose. Awful stuff. And would sedate them. We thought that Librium would work, and particularly intravenously. And we also experimented with Thorazine to control it. We got the best results with Thorazine, actually, but Librium was easier for the average practitioner to handle. So we started to set up guidelines for how to use that as a sedative in DTs and in severe alcohol, just the shakes sometimes, and get them under control. And then we would usually turn them over then to a social worker or a psychiatrist or somebody to deal with the non-medical side of it.
So it sounds like they were hospitalized for DTs the same way that they are today, and
Yeah, not much change,
Yeah.
other than we looked at the protocols for what worked.
right,
Right.
medication.
Yeah, we actually tried to see what was the right dosage. We tried a variety of different different durations, and we published them. Thorazine was the most predictable. That's why we liked it.
Okay.
But the physicians were really uncomfortable with Thorazine.
Okay.
They-
And why is that?
I think they were used to seeing it being used in severe psychotics, and the association, and in those people you give really high doses, and the margin of error is narrow when you get up to those very high doses. So because we had experience with it, it didn't bother us, but they associated it with this really difficult patient, difficult treatment. It's all mental. But Librium worked well for them. They were comfortable with that.
And you also mentioned MIs, and it sounds like you were sort of on the cusp of a lot of developments with MIs, and you know that there have been a lot of developments over the last 20 years and things like that. So tell me a little bit about how you guys were handling MI when they came into the hospital.
Initially they'd be put to bed. They'd be sedated, oxygen. They would get a few blood work. SGOT had just started to come in.
SGOT?
SGOT, SGPT. I know, you use CPKMB.
Okay.
That was the next level. That was next.
I see. So SGOT and SGPT were also enzyme tests, blood work tests that you could
Correct.
diagnose.
They're not as specific because they're also given off by muscle and liver. So the CPK was much more specific to the heart, or at least the MB fraction. And that came later. That was actually, I think, my senior year or second year in residency, somewhere along there. That came along. It was much better. And before that, they used some really outmoded protein tests, which are coming back now as a general marker of inflammation. But we used to use them to look for any kind of infection, inflammatory disease, and it did go up in heart disease. But I don't want to get off on that. Yeah, so bed rest, sedation, oxygen. And then...
Were nitrites around at all or anything like that?
yeah, but they only used it for the pain. There was no preventative. And then propranolol came.
Okay.
And
Which sounds like a beta blocker?
a beta blocker. That was the first beta blocker.
Okay.
Right. And that changed. That was very effective. That was big. You could actually see it. Sometimes a drug comes along and it makes a little bit of a difference. Pranolol, Inderol made a huge change because even bad heart attacks seemed to come under control with that. And lidocaine came in around then too. We used it for arrhythmia control. And again, we made a lot of mistakes. Nobody knew the dose of lidocaine to give, so we generally overused it. We had a lot of problems until we figured the dosage out.
Sure. That can be tough.
It is, yeah.
And how about on the diagnosis of MI? Was it still sort of EKG were they as available as they are now?
Yeah, EKG was readily available.
And when you were suspecting MI, you were sort of suspecting it on the same clinical symptoms that we see today in terms of chest pain, left arm
Right,
symptoms.
right. None of that. That's all very old stuff too.
Right.
Yeah, nothing new. The big problem we faced then was MIs in women who have very atypical symptoms. There was a huge controversy about whether to call them MIs. There was an argument of whether it was coronary insufficiency rather than MI, small vessel disease. There was all these arguments going on back then about how women's version of coronary disease varied and what to do about it. It was treated differently, but it turned out not to be. But making the diagnosis was harder, just based on what you were saying. They didn't get the classic pain on the arms, and it was just pressure, indigestion, atypical. They called them atypical MIs back then.
Right, of course.
Yeah.
Wow, that's very cool. So something that you and I have also talked about in past meetings is your time in the military.
Right.
Do you mind telling me a little bit about where you were, what you were doing while you were there?
Sure. I was stationed on Guam.
Okay.
It was the Vietnam War, so we were the first evac hospital out of Vietnam.
Evac hospital meaning the hospital
Yeah,
that people were transferred to immediately.
Yeah, Vietnam changed the whole medical delivery in the military. If you're probably familiar with MASH units.
I'm not.
You didn't see the show MASH? Oh my God, TV show?
I
Oh
never
my
saw
God. Okay. Well, MASH, it was a tent basically built right on the front lines. And as people got wounded or injured or sick, they were put into the MASH unit and treated.
Okay.
In Vietnam, they did it completely differently. There were stations, evac stations, so there was a MASH unit. But if you could survive to the next unit, you went to the next unit.
Okay.
And they assessed you if you could survive there, you went to the next unit. And then, so there was the MASH, there would be a regional hospital, there would be Saigon.
Mm-hmm.
Then we were in Clark Air Base in Philippines, then Guam, then Hawaii, and then Tripler or Oakland Hospital, Naval Hospital, one of those two. So at every place, we would go on the plane. So the plane used to get into Guam at 2 a.m. We would go up to the air base, which was about an hour from where I was. And we would work with the nurses, and we would decide this one can't make it the 10 hours to Hawaii. They would come off. So we would get about 150 patients off that plane each night. It's a 110-bed hospital, by the way.
Oh my God. And how many people working at the hospital?
We had about,
Docs.
yeah, docs. We had about 50 docs, I would say,
Wow.
working there. Right. A lot of Quonset huts. These aluminum, they're circular huts. They look like you took a tube and cut it in half, placed it on the ground. They're very cheap. You can build them out of nothing. They fill them with bunks. So if you could walk, that's where you went. If you couldn't walk, you went to the ward.
Okay.
And they did a lot of surgery. Medicine was mostly malaria.
Okay.
I treated almost 800 cases of malaria when I was there. I saw everything from black water fever to just routine malaria. And just as a sidelight, my first 3 cases in Southbridge when I came here were malaria.
So good training.
Yeah, somebody walked up to me and showed me a chart and said, "This looks like TB." I said, "No, it looks like malaria." And they said, "No, we don't get malaria here." But they did. Yeah, we had 3. I never had another one again, but we had 3 in the first 2 months I was there. Okay, so back to Guam. Malaria was the big thing. We had a lot of infectious disease, and we were also the hospital for the Pacific Trust Territory, which is not called that anymore. Almost everybody's independent now. But it covered a almost 2,000-mile range that can only be reached by seaplane. And they would fly them in to us. We were the only hospital really around. And we saw everything. I saw acute leprosy. Leprosy was fairly common. ALS was indigenous to Guam.
Oh, really?
Yeah, we saw at least 20 cases a year, new ones. And of course, there's not much you can do. But NIH had a team there studying ALS. And so we saw a lot of parasitic diseases from the tropical islands. I'm trying to think what else. We took care of the native population too. Hardly anybody on Guam did not have somebody in the military and therefore was eligible for care. So that's why we saw the ALS, and some of the leprosy cases were local as well. And one of the non-medical things that happened to me on Guam was the last Japanese soldier was captured on Guam while I was there.
Oh my God.
This was, 30 years after the war, 40 years after the war. He had been living in the jungles.
Right, the people who never got message from Japan.
Right.
Yeah.
He didn't know the war was over.
Oh, that's tragic. Oh, God.
It is. He was quite a hero, by the way, when he went back to Japan.
That's good. You deserve something.
He deserves something for that, right.
Wow, so that's quite an experience.
Right.
So you then came back having done this and you went straight into practice from there, is that
Correct.
right? And so when you started up your practice, you went into this small group of physicians.
Right.
Tell me a little bit about your patient population at that time.
It's pretty much a primary care population. The hospital was a little different then. It was run by the family practitioners. Most of them were quite old. The hospital staff at that time was probably about 15 or 20 people. Now it's about 60. When I came, they had just hired a new administrator who was a graduate of Cornell School of Hospital Administration, so he was a go-getter. And they had just built for him a brand new wing. So the hospital looked signs of expanding and growing. He turned out to be quite a guy. He recruited an amazing group of physicians. So there was a conflict going on in those early days between the family practitioners used to running the place, who were now being outnumbered and being outvoted. So the president of the staff, the last president of staff was the year I came, was family practitioner. None after that. They were all replaced by the new specialists that were coming in. In fact, I was president, I think 4 years after I came. When I came to town, I was expected to visit every physician and say hello.
When you moved into the Worcester area?
When I moved into Southbridge. Yeah, everybody there expected me to come visit and say hello, and essentially promised not to steal their patients. They didn't say that, but
Really?
it came pretty much, you could tell the tenor of the conversation what it was going to be.
Oh, that's so interesting.
You know, we're not going to refer to you if you, they didn't use the word steal,
No,
but if you retain my patient after I give them to you,
wow.
you will not see any more referrals. Now, it was more subtle than that, but that was the tenor of it. With only 15 docs, it wasn't that hard. When we got up to 50, 25, 30, or 40, that started to go away. Back then, I was also expected to become a member of the medical society. And in those days, you had to go and meet with a board of censors at the medical society to be approved for membership.
So let's talk about, what was the board of censors? I don't think that we have that.
No, we got rid of it probably 6 years later, I think, something in that ballpark. They were senior physicians, much like the executive committee, but the older members who've been there a long time. They were very impressive people, by the way. They were. I was quite impressed in meeting them. They really knew their business. They were very nice, and they told me, in South County, the system worked differently in the medical society then. There were 9 hospitals in Worcester.
Okay.
And
it's a lot of hospitals.
yeah, there were 16 in Worcester County.
Oh my God.
And what are we down to, about 5, 4 now, something in that ballpark?
Not that many.
But, so the 9 hospitals rotated as president of the medical society, and the 10th one was everybody else. So when I was president, I was the year that everybody else, because I was outside of Worcester. And so they would interview you, decide, and their parting statement to me was, don't vanish, because you were required to join, but nobody from South County ever was active and never took part. I was the antithesis of that. I'm very active. I was on PSRO, which was the Medicare review agency here. It got replaced later, went away. Central Mass Healthcare, I was one of the founding people of Central Mass Healthcare and the foundation. And trying to think of what else.
So come back to the Board of Censors.
Board of Censors, right.
It was an organization that sort of you had to get approval from to practice in?
Yeah, they were members of the medical society, and they interviewed you. You got to put an application in, and they would ask you some questions, and then they would say, well, okay, we accept you for membership. And then you
would be allowed to practice in the hospital?
Well, the hospital did not require you to be a member of the medical society, but the culture required you. There was also a Southbridge Medical Society, which was really more of a monthly beer and chips meeting, just keep the sort of illusion of camaraderie going. And I was president of that for a year. I made them say going to the bar while they were having an election. I came back and was elected.
Great, that's the way everybody
That's the way everyone works, right?
That we're filming today, the day before the presidential election in 2012, and I can imagine that they would be feeling the same way. So tell me, what were some of the issues politically that you guys were discussing in those days? What were some of the big problems?
Well, the biggest one probably, not so much for us in Southbridge, but in Worcester, was the Fallon Clinic and the HMO, development of HMOs, because everybody feared it was going to change practice, which it did. And there was a lot of worrying about consolidation and loss of hospitals. You could start to see the handwriting on the wall. Small hospitals were going to go. They could not compete.
Related to the development of HMOs?
Partly from that, and partly just from the economics of it all. Sure. I was president in 1982 of the Medical Society, and one of the first things I had to deal with was the Business Coalition on Health. They formed the big players, Norton and all the big players in Worcester had formed a coalition on health to try to dictate and control how healthcare was going to be delivered.
So this was insurance companies doing this?
No, it was done by the businesses because their insurance rates were rising through the roof.
The businesses were their employees.
Right.
Okay, for employee health insurance. All right. So they had developed this coalition, and they were sort of fighting pro-HMO, presumably.
Correct. They wanted HMOs, but they were also aware that there could be some problems, that HMOs might cut corners, because the Medical Society had been preaching that this was a dangerous approach, and that the idea of health maintenance hadn't really been proven, that nobody really was quite certain that if you did all these things, you actually would reduce down the road the cost of care. That was the basic premise, and in the 70s and early 80s, there was very little research to back it up. It just seemed like a good idea, but they were worried about it. So the first time we voted on this on the executive committee, they wanted us to join the coalition as a representative of the Medical Society. The executive committee voted it down, actually 11-0.
Wow.
So I joined it anyway. I told them, well, the medical side doesn't want to, but I'll come if you'll let me come, and I'll represent them. So they did. I was on it for 2 years. Then all of a sudden, the medical society wanted to be on it because I was independent. They couldn't actually tell me to deliver X message, so then we suddenly realized that, and the next vote, it was 11-0 in favor of backing me up and supporting it. Anyway, we jumped quite a bit around, but the big issues were consolidation of hospitals, HMOs, Medicare was becoming big. It had been voted into the 70s, but it really hadn't started to dominate, and the feds weren't really starting to take control. The PSRO, which I had mentioned, probably totally alien to you.
Yeah, very alien.
That's Professional Standard Review Organization, and what they did is they peer review, but they did it by aggregate hospital data, and then they would tell some physicians that their numbers weren't good.
So where did they get the a
from the
big
Medicare
discussion.
forms.
Medicare, so like paper forms,
Right.
for all the paper.
Right. Every hospital, when I came to Southbridge, the Utilization Review Committee document that says, here's what you do, was one side of one page, didn't even fill the whole side. 15 years later, when I left practice, it was 110 pages, something in that ballpark, because of all the regulation from the feds and had changed it. And they started to demand more numbers, more information, individual patient records. They could look at any patient record they had paid for, which initially wasn't much. It was small numbers that got bigger and bigger, became the dominant player in the hospitals. And then they had the clout to start saying, well, we're not going to pay for this, or we're not going to pay for that. So then that became the next big issue. So Medicare was in the 80s, late 70s, 80s, had become a dominant factor.
So, I mean, it's fascinating to me that, you practiced in a world where Medicare was not sort of a dominant factor because...
I practiced where it wasn't even there at one time.
Right. That's crazy to somebody who,
It's just part of your being, right?
Right.
Right.
So, when you first started out, when Medicare, first came about, was it as difficult to get reimbursement from Medicare as I understand that it is now?
Well, I never had a problem, to be honest. I think because I walked into a system that was already there. I think the problem with the older docs, not even the older docs, even the middle-aged docs, was they resented the loss of their independence way more than the payment issues. To me, this is just how it was, and having come out of the Navy and all the bureaucracy we dealt with there's no independence. I mean, I could tell you some stories on that too, but I just think they had trouble adapting to it.
So by loss of independence, you mean that there were these certain criteria that they had to meet in order to get reimbursement?
And some things they just wouldn't pay for.
Yeah.
You're not qualified to do that. Malpractice, too, was exploding at that time. So it was another big issue. My malpractice premium when I started practice was, I think, $80 a year. And 15 years later, when I left, it was like 5,000 or 6,000. And that was before it really shot through the roof because it really went out of control. But I would get from the insurance company each year, I used to do liver biopsies. I got a report one year, I was paying $500 at that point, I think. They said, well, you're going to be $1,000 if you keep doing liver biopsies. Well, I don't think I made $500 on liver biopsies back then, so okay, gone. So unless it was worth your while, that's how some of the dictation started. They just would not pay for it.
So before Medicare, or when Medicare was in its infancy, did you find that there was a big difference with how people were paying? Were more people paying out of pocket? How did that
There was
work?
very little out of pocket, but more than there was later. There were some people, it was very small. Most people had insurance by then.
So how were people who retired, where did they get their insurance from?
Well, you could buy insurance. It wasn't as expensive then as it is now.
Okay, so more people were buying from...
You could buy it, right,
individuals.
right.
So it wasn't necessarily like a retirement benefit at that point. It was
Right.
more along the
And
lines.
mostly through Blue Cross and Blue Shield.
Yeah.
But they had policies for the elderly. I know one thing we should talk about.
Yeah.
I had the second nurse practitioner in the state working for me.
So tell me a little bit about that. I mean, again, we're in a world right now where...
1974.
Yeah.
I had just come out of the military. And in the military, the corpsmen are classified from A to F. And the idea was a Class F corpsman, almost like a mini doctor. They could do thoracotomies, they could do appendectomies. And they were stationed on small coral islands. We were not supposed to know what was there, but they were, of course, missile bases. And so you only need a staff of about 10 people to run a missile base. Well, you can't put a dock there. So the Navy was responsible for all the islands.
So they used local alliance workers.
And they figured this out And what happened, of course, is Duke University, all these guys were leaving the military eventually. And they had these highly trained guys, and they thought, well, why don't we create this thing called physician assistant? And they took these Navy guys, the corpsmen who had been in the, at least from level E and up, didn't have to be an F, and they trained them in their program and sent them out. And I watched these folks, and I said, there's no reason you can't use these kind of people to do almost everything. I mean, there's only a handful of stuff they can't do. So I hired an ER and ICU nurse, and I told her, we're going to break some ground here. And I got privileges for her in the hospital to see my patient. That was a big fight.
Tell me a little bit about the reaction when people saw you employing an NP.
The young guys were all interested.
Yeah.
They all wanted to see how this worked.
Yeah, sure.
Because if you got a call from the hospital about something, I didn't have to leave. I could send the nurse practitioner over,
Oh, okay.
and she would tell me, because she made rounds with me in the morning and in the afternoon when I made the second rounds. And she would come and tell me, well, it's this, this, and this, and it really hasn't changed in the morning. All you're dealing with is the nursing shift has changed, and they're nervous. So that's fine. Okay, we don't have to do anything. She made house calls with me. We did house calls in those days.
Yep.
Every day from, my office hours were from, I made hospital rounds from 7 to 9. Then 9 to noon was morning. Then from noon to 2, I did house calls or lunch, whichever was more higher on the priority list. Then from 2 to 6 was my afternoon hours. On flu season, it could go a lot later. So she would handle all of that, and they were pretty impressed, actually, how much work that could save and how many more people a day I could see. We were seeing, when I started, of course, I didn't see that many patients, but in the end, we were seeing 60 to 80 people a day. That's a lot of patients pushing through.
That is it.
And some of them are simple, immunology, shots and stuff. But so anyway.
But it sounds like overall it was pretty well received when it
was.
first took on. And then how long did it sort of take for other people to sort of pick up?
Not till after I left, actually, strangely enough. I was surprised. I thought there were others that were going to do it faster. It was the surgeons who were the fastest next into the line.
Interesting.
Yeah, because routine post-op checks, removing sutures, a lot of really simple stuff that was eating up their time. They could get rid of, and they began to see that. But they were waiting until there was an official nurse. There wasn't an official nurse practitioner program until 78 or 79. They wanted a certification. There was none. She took the PA program, which did have a test.
Okay.
And she took, there was a national PA test, she took it. And then Mass General ran an 8-week course to be a nurse practitioner. And she took that and then passed the certifying test, which...
An 8-week course for a nurse practitioner.
Right.
Wow.
Different world.
Yeah. So for those who don't know, right now our nurse practitioner is usually a 2-year program, full-time, after your RN.
Correct. And then slowly and steadily. She said, by the way, that the PA test was harder than the NP test. Said it was way harder.
Really?
Yeah. She said they just asked tougher, more difficult questions. Now, I don't know what today, we're talking about in the 70s, so we're talking a long line back. But yeah, so anyway.
Wow, so that sounds like a really amazing experience.
It was. It was. Training somebody and breaking new ground, which is actually what I like to do.
So let's talk a little bit, you mentioned sort of the general structure of your day.
Right.
So let's talk a little bit, first of all, about what kind of patients, or not what kind of patients, but what kinds of diseases you saw most frequently in the early years of your practice.
Well, initially I did start really as an internist, and it was a classic internist role, which doesn't happen much anymore. So almost everything was consulting, probably 3/4 of it. And then slowly the outpatient practice started to build. And so the outpatient practice was mostly people I'd seen in the hospitals, but also the usual primary care, colds, strep throats, ear infections.
So you mentioned internal medicine as a consulting role, which is something I'm not familiar with at all.
Right, it's how it started.
Yeah. So do you mean by that you were consulting in hospital?
Yeah.
Or, so tell me a little bit more
Today,
about that.
today your hospitalist would be
Yes.
closest to what we were, except, well, no, it wouldn't be. So my privileges in the hospital initially were to handle the ICU, ER consultation, and consultation. And physicians could turn cases over to me in the hospital, but I did not admit them. And eventually my privileges changed to family practice as well, because I was starting to build my own patient repertoire up. So mostly it was CHF and MIs,
Okay.
by far and away. And then unknown problems, and stuff people didn't want to take care of, like DTs.
Sure.
Trying to think of what was the other big one nobody wanted. No, it'll pop in my head. But there were some things that just didn't want the nonsense with you. You had called all during the day. And if it involved nighttime calls, they were really happy to turn them over to me.
So how did night call work, or how did call work in this sort of setting?
Well, I was in a three-man group, but we were three independent practices. We just had an agreement for coverage, but we were very close, very, very close to each other. So Monday, Tuesday, Thursday, and Friday, you covered yourself 24 hours. Wednesday, everybody was on till noon, and then we rotated. Somebody, every third Wednesday afternoon, you were on call, and you also had that weekend. Most of us did have hours on Saturday also, but if there was a call in the hospital, the coverage guy took care of it. You could call if you really got into a jam, you could call the guy whose patient it was and say, I'm not sure what's going on here. Didn't happen very often. It was considered a major breach of etiquette.
Yeah. But I mean, it's important to have that.
Yeah, but we've had a good relationship. I like these guys very much. We eventually picked up a fourth guy who wasn't as good.
Okay, fair.
And it's just the breaks of the game. He was a nice guy, but he was not as competent as we thought he was. And it's hard to break those up once it happens. Once you have a group going, very hard to break it. So after about 3 or 4 years, the outpatient practice had now built up pretty high. By the way, my office fee was $8 back then.
Oh my God.
Full physical hour was $20.
Wow.
Yeah, amazing. Different, very different world. Very different world.
So you built up your outpatient
That's right.
practice.
And it's mostly the typical family practice stuff. I took kids down to 5. I did a pediatric internship at part. I half internal medicine, half pediatrics. So I was comfortable. I was actually comfortable with younger than that, but I felt it just didn't. I was going to be stepping on a lot of toes. So I took them at 5, and 5 and up. And I had a lot of kids. There were a lot of kids, a lot of families. They wanted to stay in one place. I didn't do OB or anything like that. I delivered 100 kids, though, in medical school.
Wow. In medical school?
Medical school,
100 babies.
Yes, and 40 of them with forceps.
Wow. So pretty intense
Yeah,
deliveries.
yeah. It was, well, remember, the size of this hospital.
Sure. And also, I can imagine the malpractice
Was very
structure was different.
Very different, right.
I know when I was in OB, I had my hands on maybe a couple of babies during my OB rotation.
Right.
It's
No, they counted on us.
Wow.
We were busy. We walked in, we watched one, and then they said, you're doing the next one. And I just did one after another after that. And in that hospital system, in that medical school system, when you were in school, there were 5 peripheral hospitals. So the Kings County was the big one. There was Cumberland and Montefiore, and there was Coney Island. And you rotated through them for different services. And I did OB at a hospital that mandated forceps on every delivery.
Now, what was the theory behind that?
I have no clue. I I have no clue. But I tell you, I got very good at forceps.
Wow, yeah, I bet.
We did I did 30 or 40 or 50 maybe deliveries in that hospital. I think 40 of them were forceps. There were 10, they didn't need me, you know.
Yeah,
You got this women with 8 babies. I'm just recording notes and filling the birth certificate out. You know,
I've seen those.
she could tell me more about this than I could tell her.
Very true.
Right. And it was a few we delivered in taxis on the way, you know, in the ER. But the volume is enormous. You have to see a place like this to appreciate it.
I understand that New York hospitals are still very similar to
They are, yes. I have friends who still
Yeah.
go there or teach in some of those places, some of the same hospital actually. It's a steady stream. There was no quiet time. 2 a.m. in the morning, you know, there's 100 patients sitting there waiting to be dealt with. It was endless. As a medical student, we loved it. We went in to suture, and every night there was some knife wound to suture up to.
Wow.
We lived there.
And I can imagine, too, that with surgery and with the ER as a medical student, you were doing sort of the same level of care.
Right.
I've heard from other residents, or other doctors during their residency, that they were sort of in the OR by themselves, and the attending would sort of float in and float out.
Oh, yeah, very true.
Yeah.
You know, the thing I liked about the county hospitals was, A, we could turn nobody down. By law, we had to take everyone. So we got dumps from all over the place. But we were busy, and we had a lot of good patients. We ran the patient, the interns, right from day one. And because they were overloaded, they passed stuff off to the medical students left and right. So it was a great learning experience. And I had friends in the private hospitals who were lucky if they could write orders in their first and second year.
Yeah, I'm sure.
Right. So it was a great experience.
So how about, younger physicians starting to get into medicine, into practice? Work-life balance is always an issue. And it sounds like with 36 on and 12 off, it was always an issue. So how did that work for you? What was it like to be a physician with a family?
Well, the 36 on and 12 off, that was in training,
Right.
and there was no family life.
That helps.
It was non-existent. But in practice, with 2 out of every 3 weekends off and 2 out of every 3 Wednesday afternoons off, plus the backup of having 2 close partners essentially to work with, no, I don't think it had much impact at all. We pretty much did what we wanted. But I had a pretty good idea of what I was looking for, and I accepted this place because of the two guys I was going to work with. The hospital looked promising, new administrator, brand new wing. It looked like they were far-sighted, looking ahead. But the 2 guys were what determined it for me. I felt that a good personal relationship would mean everything down the road, and it did. They were fantastic people to work with. So my family life was great during my practice time. We just had a very good setup. And if I needed to do something, like when I became president of the Medical Society, I spent a lot of time in Worcester. Somebody had to cover me. And before I took the job, I said, hey, look, this is what's going to happen. Are you guys ready to do that? And they said, yeah, we'll do it. So they covered me a lot, way more than every third.
So that's amazing. I mean, that's great to have that support
Right.
with your practicing physicians.
Right. They were a great bunch of guys. They're both passed away now, but it was just terrific working with them. And so, let's see. You were going to say advice to.
Yeah. So and one of the questions I wanted to end with is going forward. What sort of advice do you give to younger physicians that you meet, or what's the most important piece of advice that you feel an older physician can impart on a younger physician?
Well, I suppose, first of all, I'm actually jealous of the students today.
And why do you say that? I'm very curious.
I think your program is way, way better. I think there's a bigger focus on actually delivering medical care. There was far less of a focus on that when I was in training. When I walked into practice, my first patient was a sore throat. I had no idea how to treat it. They came in with a knife in the aorta. I probably could have handled that with my eyes closed.
Fair.
But a sore throat, I had to go talk to my partners and say, what do you do with a sore throat? I've never treated one. So the whole idea of delivery, of how you handle it, how you run a practice, there was no help whatsoever.
So in terms of more like outpatient management, you didn't get
Right.
much training in that?
Hospital stuff, I was no problem. I mean, the consultant stuff that I was doing was right up my alley. And they trained me well for that. But in terms of ambulatory care, very poor, very poor. I like that nowadays, too, there's some chance to break and do some overseas stuff or some community service stuff. I think people should take advantage of that.
Do you feel like your overseas experience, and it sounds like it really has affected the way that you practice?
Oh, yeah, very much so, because of working with the corpsmen. And the Navy was a strange experience. I loved Guam. I actually liked my time in the Navy, but the Navy bureaucracy was horrendous. And particularly in wartime, it was particularly sad. Alcoholism, huge problem. So my advice is to take advantage of what's available to you in school. Look at those opportunities to break training and do something else, because afterwards you're caught up. You're not going to get those opportunities to try other things and see what the world is like. Try going to some underserved area, or even overseas if you can, or stuff like that. And that would be the big thing. Try to find what interests you. That's probably the hardest part of all. For me, it was a much tougher choice. It was between internal medicine and psychiatry, actually.
Wow, that is a big difference.
Yeah.
What swayed you over to internal?
I think if I went through it today, I would probably go to psychiatry. But the treatments available back then were, remember, Librium was just coming in. And this was this whole new idea of tranquilizers. It was breakthrough stuff. The drug capabilities was minuscule. It was mostly psychotherapy. It was a lot of it was sedation. And I began to realize it was a lot of fun working with these people, but the armamentarium was really weak. Internal medicine had a lot more opportunities. And it too was bursting open with new drugs and new treatments. So, today are standard, but back then everything was coming up out of the blue. Somebody would be hearing about some new drug out there, and we'd go and find it.
Wow, so quite a feat. But you enjoyed your time in internal medicine nonetheless?
I did, yeah. I ended up closing my practice to start a medical software company.
Really?
Yeah, so in 1984, with 4 other people, we started a medical software company called Mediqual.
Medical. So of course I'm familiar with that, having been Dr. Carlin's
Oh, sure.
longitudinal preceptor student. So.
He worked for me.
That explains a lot. Yeah, that makes a lot of sense. So tell me just a little bit quickly, what was Mediqual?
Mediqual, there was a type of product on the market that determined whether you could stay in a hospital or not, and it worked on the severity of illness idea. So a potassium of a certain level would justify hospitalization, but you could also add things together. Some things that might have been borderline, you have 2 or 3 borderline lab work, that would justify it. So the big problem that came, that it worked well. That company is called Interqual. It's still in existence today. It was my last job after we sold the software company. But everybody was being judged by Medicare on how well they were doing, mortality rates, costs, and of course their answer was, but my patients are sicker, that's why more of them are dying. So we thought we could come up with a statistical algorithm that would say, yeah, you're right, we could adjust this based on the laboratory values, based on the EKGs, et cetera, and come up with a number that said, here's the expected mortality for this patient. Compare that to their results. And it turned out that about 80% of hospitals indeed did have higher, sicker patients with the higher mortality. But that focused you down to a 5 to 10% that the clinical makeup did not explain the mortality rate. And we were eventually mandated by 3 states to every hospital and state, Pennsylvania, Iowa, and Colorado. Interesting states, given tomorrow's events.
Right, of course.
And in one of those, Pennsylvania put it in all 200 hospitals. And the first thing we did was cardio bypass surgery. And 3 physicians stood out with very high mortality, and the place erupted. I had to go to Pennsylvania and defend the process, and we had rooms of screaming surgeons. But the 3 guys eventually closed their practice and left the state and went to Florida, where they had the same bad results.
Wow.
So we actually had found 3 bad performers.
Sure, of course.
And so we felt great.
Yeah.
It worked.
That's quite an experience, too.
It was, because we worked a lot with, we had some great statisticians, and building statistical models is, for me as an ex-engineer, was a lot of fun. So we would try throwing different things in to see if we could explain variation. So you found things, for instance, like potassium has a triple curve for mortality. Very low, then there's a kind of a borderline group, and then there's another high end. And some have 4 periods where they're at risk. And so it started to be rather interesting in saying, well, now you could sort of predict this as a patient to worry about. So maybe, and that's what we sold the company, that we could do this to tell them at the front end that you've got a bigger problem than you may be thinking of.
Oh, that's so interesting.
Yeah. That was a lot of fun. I was there 11 years on that project, and then we sold it.
Well, Dr. Steen, I think that we should probably wrap up.
Sounds a good place.
Thank you so much for your time today, and it's been great talking to you.
Good. It was a lot of fun. Who's going to be your next one?